Our discussion today will be on treating Alzheimer's disease with Donanemab. So the objective is to explore Alzheimer's disease as a neurocognitive disorder and discuss Donanemab use as a new treatment along with a little bit of background about the pre-existing treatments that are used to treat this disease. Before we discuss the medications that are used to treat the disease, we need to understand what disease are we treating. So essentially, Alzheimer's disease presents with cognitive symptoms such as memory, attention, and visual perception deficits. Some emotional symptoms include anger, frustration, depression, and anxiety. The somatic symptoms include loss of balance and muscle weakness, while our behavioral deficits include refusing help, hoarding, and sometimes repetitive behaviors. So Alzheimer's disease essentially affects our hippocampus and amygdala, responsible for memory formation and emotional processing centers of the brain. So essentially, at the microscopic level here, we have our alpha secretase normally cleaving amyloid precursor protein, but abnormally we have beta secretase and Y secretase that cleave the amyloid precursor protein improperly, essentially causing beta amyloid plaque formation. Additionally, we have hyperphosphorylation of tau proteins, which are normally used to stabilize the microtubules in our neuron cells. However, because of this phosphorylation, tau proteins detach from microtubules and they form these neurofibrillary tangles, which essentially lead to the cytoskeleton collapse of our neurons. This image here shows the disintegration of our microtubules by the hyperphosphorylated tau proteins and the beta amyloid plaque formation. Essentially, the disintegration of our cytoskeleton because of the microtubule disintegration could be essentially neurotoxic and cause neuron cell death. This image just shows a close-up picture of kind of two neurons and the beta amyloid plaques that are accumulating, which, as you can see, may cause an issue in communications between one neuron and its subsequent neuron. The current treatment of cholinesterase inhibitors essentially try to increase the levels of acetylcholine in the synaptic cleft. So these inhibit acetylcholinesterase, which are normally responsible for the acetylcholine breakdown. And the hope is that if we increase acetylcholine inside of the cleft, the deficits seen from the beta amyloid plaque and barriers in communication will be surpassed by this increase in the excitatory neurotransmitter of acetylcholine. There's also NMDA receptor antagonists. So these NMDA receptors are essentially activated by glutamate to allow ions such as sodium, potassium, and calcium responsible for generating an action potential to pass through the neuron cell membrane. However, beta amyloid plaques cause glutamate to not be recycled like it normally would in a non-pathologic situation. So essentially, the NMDA receptor antagonist will block glutamate's effect on the receptor so that the receptor cannot be activated, the channel cannot be activated, and these ions cannot diffuse through and cause issues in signal transduction. Essentially, these NMDA antagonists can bind competitively, rate directly to the receptor, non-competitively, kind of altering the integrity of the receptor, or uncompetitively, where they block the channel from the inside out. Donanemab is our new treatment, and it is an anti-amyloid antibody intravenous infusion. So that means that it directly affects the amyloid plaques, and it is administered intravenously. And Donanemab is used in early stages of Alzheimer's disease. Some of the benefits of Donanemab include slowing the progression of the disease, as well as faster amyloid plaque reduction as compared to what is seen in lecanemab, which is another medication that's used in the treatment of Alzheimer's disease. The limitations, as pretty much analogous with all other treatments, it cannot restore or reverse cognitive function that has already been lost. And the side effects include amyloid-related imaging abnormalities or small measures of edema and microhemorrhages seen on imaging, as well as headaches. The mechanism of action of our donanemab is essentially it binds to the position 3 of our proteoglutamate modified beta amyloid plaque. So it just essentially binds to a certain position on our beta amyloid plaque. And because it's a monoclonal antibody, this then will stimulate our microglial cells. So the FC region of our donanemab is going to then want to bind to our FC receptor on our microglial cell, and then our microglial cell is going to want to phagocytosize the antibody as well as the beta amyloid plaque. In the clinical trial of the donanemab, the Trailblazer ALZ2 clinical trial, essentially the population was of early stage Alzheimer's patients with dementia and the presence of amyloid plaques. And it was a randomized double-blind control trial that lasted for 18 months. And the results seen were a reduction in beta amyloid plaque, and especially a 35% reduction of cognitive decline in the patients that were receiving the drug. There was less progressive deficits in activities of daily living as well, and it was found out that donanemab acts as this immune-mediated clearance because of this, because it is a monoclonal antibody. Right now, currently, the donanemab has not received full FDA approval, but it has been under review since the year of 2024. The question that we might ask is, why is donanemab superior to a cholinesterase or NMDA receptor antagonist? And this is because donanemab is a disease-modifying treatment. So essentially, the ACH cholinesterase inhibitors increases the ACH in the synaptic cleft, and our NMDA receptor antagonists basically try to restore signal transduction to compensate for the plaque formation and the neurofibrillary tangles. However, donanemab works directly at the phagocytosis of our plaques and tries to clear these beta amyloid plaques from our body. So essentially, like I said, it offers this disease-modifying approach. Another question we might have, so how might future therapies in conjunction with donanemab be used to treat Alzheimer's disease? So essentially, donanemab kind of tries to phagocytosize the beta amyloid plaque once it's already formed. However, there is a donanemab, which binds to the N-terminus of beta amyloid fibrils to try to block the aggregation into a plaque. So essentially, it targets at the oligodimer stage and tries to prevent that plaque from forming. And like we mentioned before, lecanemab selectively binds to our beta amyloid oligodimers also, and trying to prevent that plaque from forming to start with. So we may also ask the question of, why do you think some patients may not benefit from donanemab? So essentially, patients that have late onset or late progressive Alzheimer's disease may not benefit from donanemab because once we already have a significant amount of neuron cell death, there's no reversing that. Neuron cells are permanent cells that have entered the stage of G0, and they do not undergo mitosis once they're fully differentiated. So essentially, once we've already had a significant amount of neuron cell death, there's no reversing that process. So essentially, donanemab is seen in the best treatment in early stages of Alzheimer's disease. Thank you for listening.